Chopra, you can start and then I will take.
Good evening, everybody. Welcome to this Heart Failure Masterclass. In these classes, our master teachers have analyzed the history and signs and symptoms and physical signs in great detail. And I think they have taught us how to get the maximum information from what the patient is telling you and what are the findings on simple examinations. This is especially important because clinical examinations seems to be a dying art in most of the places. So it's wonderful to see how much information you can get from proper analysis. So over to Dr. Harikrishnan to take us through the next session.
Thank you, sir. Today we have this is the second edition of this year, 2026. We have first a basic talk on basic analysis of randomized control trials will be done by Dr. Jiman, who is our epidemiologist at the Achal Menon Center at Sri Chitra. Then it is followed by a case discussion. The students will be presenting from Calicut Medical College, and the discussing students will be from Sri Chitra Institute. And after that, the highlight of today is the OSCE quiz, where it is open to all attendees. They can win attractive prizes like Amazon gift vouchers and a golden pass to the next Heart Failure Association of India conference in Trivandrum. So it is open to all, not the students alone. It's open to all who attends. So everyone be ready. So over to Dr. Jimon for giving the talk on analysis of RCTs.
Good afternoon. Thank you, sir. I hope all of you can hear me.
Yes.
And can you also see the slides?
Yeah, we can see your slides and hear you. Please go ahead.
Yeah, thank you very much, sir. For the next 20 minutes or so, my attempt is to give you a snapshot of how to analyze randomized controlled trials. It's very difficult to do that in the 20 minutes. So I'll stick to the basic essential concepts in terms of analyzing RCT. Some of the numbers and how we can handle those numbers during the analysis stage. So first of all, why do we, although we say that RCTs are important based on the evidence hierarchy, they sit at the top of the evidence hierarchy, there are situations where it is not possible or practical to consider RCTs. So I'm not going to get into the details of it, but just to tell you that RCTs are not always possible. There are certain situations where it is almost difficult for us to do due to ethical reasons or in practical large sample size, because some of the rare events, it takes a longer time to occur, to see the incident events over a longer period of time. And in such instances, it is almost difficult to conduct an RCT. So in the RCT, the basic element, the crux of the RCT comes from the fundamental principle where the group must be alike in all important aspects and only differ in the treatment each group receives. And in practical terms, the two groups should be comparable to each other. We always talk about this. You can only compare apple versus apple or oranges versus oranges. So we wanted to see that on an average, the two groups are comparable to each other. And how do we achieve that? We do the magic technique called randomization. When we run that randomization, if it is done appropriately, if it is done without any bias, then we presume that if it is done on a reasonably large number of individuals, not only in terms of the measured confounding factors, even in terms of the unmeasured confounding factors, we assume that the two groups are going to be comparable to each other. And as I said, if it is done appropriately, and if it is done in a reasonably large number of people, and these two groups will be comparable to each other. So the randomization will take care of all the biases that could potentially affect our study, excluding the chance bias. All other biases it will take care of. But once you've done the randomization, after the randomization, the blinding technique is the most important one. So after the randomization, the blinding, which avoids any psychological influence or in terms of the evaluation, fair evaluation of the outcome, all the biases after the randomization, the blinding procedures will take care. Now, let me introduce an important concept regarding the p-value, because now often we look at the p-values and look at the statistical significance around the p-values, and often we give a lot of importance to this p-value. So let us understand where these p-values are coming from. So now to introduce the p-value, I'm going to talk about a binary outcome, the binary outcome from the Champion-Phoenix trial. So it is a composite outcome, death, myocardial infarction, revascularization, stent thrombosis. So all these put together, the comparison is between candelabrar and clopidogrel. The primary outcome occurred in 257 individuals in the candelabrar group, whereas 322 individuals in the clopidogrel group. The total size in the candelabrar group is 5,470. Clopidogrel group 5,469. So these are the four numbers that we require for almost all the analysis in the randomized control trial. So how many number of events? The total population in both the groups, the comparison groups separately. So if we have that figure, we can run almost all the analysis. So as you see here, there is 4.7% primary outcome event rate in the candelabrar group as compared to 5.89% in the clopidogrel group. So the question that we are going to ask after getting these numbers is, do these observed results reflect a real difference? Or is it due to a chance or simply by chance? So as I mentioned in the beginning, randomized control trial, if it is done appropriately, it will take care of all biases except the chance bias. So there is a chance factor involved in it, and we wanted to see how much weightage we can give to that chance factor. So to generate the p-value, as you all know that we will definitely have a null hypothesis. The null hypothesis would say that both the approaches are equally effective. Both the treatment groups are equally effective. There is no difference between the two treatment groups. So now we are going to ask a question. If that null is true, if the real truth is the null hypothesis, that is a real truth, then what is the probability of getting a difference? So the difference that we are getting in this trial is 4.7%, 5.89%. So what is the probability of getting a difference of this size or even bigger than this size? So that is the p-value that we generate. So what is the p-value? So given the null is true, what is the probability of getting a difference of either this much or bigger? So if that probability is very small, so what we say that no, we reject the null hypothesis. So that is what we are going to do with the p-value. So what does the p-value actually mean? First, we assume that there is no difference. And then we ask this question, what is the probability of seeing result as large as ours by chance? The smaller the p-value, the less likely the chance explains the result. So that is the way that we interpret the p-value. But unfortunately, when we come to the literature, we always comes up with this artificial threshold of 0.05. I will come to that, what is importance or relevance of that 0.05 artificial threshold that we apply to the p-value. So in the Champion-Phoenix trial, the difference was 4.7% versus 5.89%. And when we run the p-value, we are getting a p-value of 0.0055. So assuming that this trial is unbiased and what the results tell us, how do we interpret this p-value? It is important for us to understand that, because often we go for, oh, this is statistically significant, this is statistically not significant. That doesn't have much weightage attached to it. Let me explain what is the appropriate method to explain this p-value. So to interpret this p-value, we could easily say that there is strong evidence that the risk of primary endpoint, in this case the composite endpoint, is decreased with the candelabrar group. And if the null is true, result of this extreme would only occur in 0.55% of the trials of this size. Or if you are going to run this trial 180 times or 180 times in different, simultaneously in different countries or different places, only in one of such cases we would get a study result of this size by chance. So we are willing to accept that chance because that chance is very, very small. And that is the way that we interpret the p-value when it comes to the p-value. But traditionally, what do we do? Traditionally, we look at the artificial threshold of 0.05 and see what is the probability of seeing a treatment difference as large as or by chance. And we say that if the p-value is less than 0.049, it is statistically significant. But then I can ask a question, what if the p-value is 0.05951? Are there any differences in terms of 0.049 and 0.059? In reality, there is actually no difference, because if you look at the way that we are going to interpret it, if you convert it into 1 by 0.049 or 1 by 0.051, we almost get the same number. So there is hardly any difference between these two numbers. So why this number, this artificial threshold is coming? It is largely because of the ego issues between two statisticians in the early days of the development of the statistics. Pearson developed the tables of statisticians with extensive documentation for p-values. And then later, his colleague Fisher developed statistical methods for research workers focused on specific selected p-values. So Fisher actually produced these tables of significance level to save space and avoid copyright issues problems with Pearson, and whom he disliked. And that is where this artificial threshold of 0.05 has been given a lot of weightage. And unfortunately, even these days, we are following this magic figure of 0.05. So now let's come back to the Champions Phoenix numbers. We know that the difference is 4.7% versus 5.89%. From this number, what we could do, we could calculate the risk ratio. So what is the risk ratio? It is a percentage in one arm versus the percentage event rate in the other arm. So in this case, the event rate in the first group, cangrelor group, is 4.7%. In the clopidogrel group, it is 5.89%. So the risk ratio is 0.80. So when the risk ratio is 1, we say that there is no difference. So both the groups are equal, comparable. And if the risk ratio is less than 1, as in this case, we can say that cangrelor is a better option than clopidogrel. If it was more than 1, then the cangrelor group is worse group as compared to the clopidogrel group. So this is estimating the magnitude of the effect in terms of the risk ratio. Now we can also calculate the odds ratio from it. The same numbers. I'm not changing the numbers here. So what is the number here? 4.70 upon 100 minus 4.70. This is the event rate in the cangrelor group, divided by 5.89, which is the event rate in the clopidogrel group, divided by 100 minus 5.89. What is it? P divided by 1 minus P in one group, all divided by P divided by the 1 minus P in the other group. So we are getting an odds ratio of 0.79, which is almost equivalent to the risk ratio that we are getting in the previous calculation. So if it is done appropriately, if it's a large trial, then the risk ratio and the odds ratio are almost going to be exactly the same. Now we are going to further effect estimate. The risk ratio now we calculated, it is 0.80. From the risk ratio, we can calculate the relative risk reduction. So what is the relative risk reduction? It is 1 minus the risk ratio. In this case, 1 minus 0.80. And to convert that into percentage, we will multiply it by 100. So in this case, 1 minus 0.80 multiplied by 100, we get 20%. So the relative risk reduction is 20%. We can also calculate the absolute risk reduction. So what is the absolute risk reduction? It's just the difference between the event rate in the both arms, cangrelor versus the clopidogrel group. 5.89% minus 4.7%. And from that, we are getting 1.1%, 1.19%, and that's the absolute reduction. And from the absolute reduction, we can calculate something called the number needed to treat, or the NNT. So if you take the inverse of the absolute risk reduction, that is the number needed to treat. So in this case, inverse of the absolute risk reduction, 1 by 0.0119, we are getting 84. What does it mean? We need to treat 84 patients with cangrelor over the trial period to avoid one primary outcome. In this case, one primary outcome is a composite event of multiple cardiovascular conditions put together. We will not be able to say it for individual conditions because it is a composite endpoint in this case of Champions Phoenix trial. So now we also need to think about how do we express the uncertainty in an estimate. To demonstrate that, I'm giving here two hypothetical trials, the trial 1 and trial 2, comparing treatment X versus treatment Y in both the trials. As you see in the first trial, the trial 1, there are 100 individuals in the treatment X group, 100 individuals in the treatment Y group. The event rate, in this case, death, it is 30% in the treatment X group and 20% in the treatment Y group. Now the second trial, the only difference here is that the total numbers are different. In the trial 2, in the treatment X group, there are 1,000 individuals instead of 100. In the treatment Y group, there are 1,000 individuals instead of 100 individuals. The event rate is exactly the same, 30% versus 20%. So now, when we are calculating the risk ratio, what is going to happen with it? Let's calculate it. So the risk ratio in this case is going to be 30 upon 20. That is going to be 1.5. So 1.5 for the trial 1, 1.5 for the trial 2. So we are getting exactly the same risk ratio. Now we can calculate something called the 95% confidence interval. So when we are calculating the 95% confidence interval, that is the uncertainty estimate that we are calculating. So in the first trial, when we are calculating, we are getting the uncertainty estimate with the lower range 0.92 to the upper range 2.46. Whereas in the trial 2, we are getting 1.28 to 1.75. So looking at the uncertainty estimate, now it is clear to us that the range is narrow in the trial 2. So the trial 1 and trial 2, you see that it's the same risk ratio that we are getting, but the uncertainty estimates, when we calculate it, the confidence interval is relatively wide in the trial 1 as compared to trial 2. And we can also see that in the trial 1, the uncertainty estimates include the risk ratio of 1. And that is where we say that we have less confidence in the results because the results could be due to chance. And when we calculated the p-value, we are getting a p-value of 0.10 for trial 1, whereas in the trial 2, the same effect size, we are getting a smaller p-value where we know that the effect of this size or larger by chance is very small. So we are willing to reject the null hypothesis and say that there is difference between the treatment X and treatment Y. So let's come back to the Champions Phoenix trial again, the 4 key numbers. What are the 4 key numbers? The total numbers in each group and the total primary outcome rates in the two groups. And based on that, we can calculate the risk ratio and the 95% confidence interval around it. If you just use the online calculator without any statistical softwares, you can generate these confidence intervals your own without depending much on the sophisticated statistical software. It's relatively easy. We just need these 4 numbers. We don't require any other additional data to generate this confidence interval or the actual p-value around it. So let me move on to the kind of types of statistical tests that we normally do in a trial. So any binary variable, yes or no variables, if you wanted to see whether that is different in one group versus the other, the normal test that we use is the chi-square test. But in clinical trials, we follow up these patients. So we are interested in time to event. So to compare the time to event across 2 groups, instead of the chi-square test, what we do is a log rank test to compare the Kaplan-Meier curves, whether there is a difference between the Kaplan-Meier curves. If you're talking about a quantitative trait like changes in blood pressure or some other factors, we normally go for 2 groups a t-test. Or we could also go for ANCOVA, which takes into account the baseline value of the outcome in the analysis. When it comes to the regression analysis, of course, for a binary outcome, we can go for a logistic regression. That's most the simplistic form. Normally, we don't see that in clinical trials because we rely on the time to event data. The most appropriate regression model for time to event is the Cox regression model. And if it's a quantitative trait, we can go for linear regression as well. But for some people who are not very familiar with the statistical softwares, we can generate these p-values from simple statistical tables of significance as well. How do we do that? We just need the same numbers. The numbers that I've shown here, the Champion Phoenix number on the bottom of the slide, 322 events in the Kangler one group versus 257 events in the other group. So I subtracted in the numerator. And in the denominator, I added these two figures together, 322 plus 257, and took a square root of that number. And that generates a value called the 2.70. We call it as the Z value. So then you go back to the Z value table and find out what is the most approximate p-value. Remember when the Fisher made this the p-value table, he made it only for relevant Z values, not for all the values. So we need to approximate here. So in this case, it is 0.007. So we can manually calculate it rather than depending on software if you wanted to do software. Finally, again, I'm giving you two slides here. Most of all of you are, I'm sure, familiar with this case. So the streptokinase trial, the first trial in the Australian trial, which involved only 517 patients, and the ISIS-2 trial, the famous ISIS-2 trial, which involved 1,700 and 187 patients. In the first Australian trial with the 517 patients, the risk ratio was 0.78. You can see that the confidence interval was wide there, but ISIS-2 trial, we are getting again the same, almost a close risk ratio, but the risk ratio confidence intervals are very tight here. If you look at the p-value, it is relatively small. So we have reasonably good confidence that this difference of this much or higher by chance is very small in this case. But if you actually look at it, it took almost 15 years from the first Australian trial to the ISIS-2 trial to get us reasonably good evidence to suggest that reasonably good confidence to suggest streptokinase is actually working very well in this population. So if you have a larger sample size, the confidence intervals is going to be tight, where we are reasonably confident in terms of interpreting our effect size, whether it is due to chance or is it a real finding. The ISIS-2 trial is also an important trial. The reviewers in the Lancet, when it was submitted, the reviewers asked the authors to do a subgroup analysis. Normally, we are all interested in, sometimes interested in the subgroup analysis and see whether the effect is more in a particular group as compared to the other group. But the authors, were not really willing to do that because they really didn't believe in a subgroup analysis. And to demonstrate that for those who are interested, you can go back and look at the literature. They did the subgroup analysis, although they were not asked to do by the zodiac signs. And then they demonstrated that for some zodiac signs, it's actually working well, and for some other zodiac signs, it's not really working well, which indirectly suggests that all these subgroup analysis that we see in clinical trial data, it's not really reliable for us to believe. It's just an hypothesis generating data. If we wanted to confirm it, we need to conduct separate clinical trials and confirm it. And with that note, I'm ending my presentation, and I'm happy to take questions or discuss any other matter related to the clinical trial. Thank you very much.
Thank you, Jeevan, for that wonderful presentation. It was very clear, and so that I think it might have benefited everyone. Any comments or questions from the faculty or the students? Can type it in the chat box also.
There's one method we use for randomization, and that is to bring together, numbers 522 or 377 are different. To make it equal, we use a permuted block randomization or block randomization, how far it's effective and how much we can use that to make it similar. I mean, between the control group and the randomization, make it similar, the number of patients, the number of
Yes, sir.
subjects.
The simple randomization works very well if there are large number of people that we can in the study. The block randomizations are important if we believe that there are multiple centers involved in the trial and the type of patients or the recruitment rate across these centers are different and their baseline risk is also different. If that's the case, what we normally do is that we could bring in something called the block randomization. And then for each block, randomization happens separately, independently, so that there is going to be equal number of patients going to the treatment arm and control arm within each block or within each stratum that we consider in the randomization. But otherwise, if it's a reasonably large trial, if there are no large heterogeneity across the type of patients involved and the recruitment rate, we do not need to really worry about the advantage of block randomization over simple randomization. But philosophically, the idea is to make sure that the two groups are comparable to each other, make sure that all other confounding factors that we are talking about, including the measured one as well as the unmeasured confounding factors, they are reasonably equally distributed across the two groups. So as I said, if you have reasonable large number, that is something that is guaranteed in randomized control trials if the randomization is done appropriately using computer generated random numbers. If you are using lottery method or coin toss, that may not be acceptable or appropriate because there is always going to be a bias the way that we toss the coin or take the lotteries.
Okay, thank you, Jiman. There are some more questions in the chat box. I think we can discuss. Yeah, the case presentation by Dr. Siddhi Lingi, Dr. Harikrishnan, and Dr. Achmal, senior residents from Government Medical College, Kozhikode. And the student panel will be Dr. Pramod Kumar and Dr. Sharath from Sri Chitra, Trivandrum. Over to the examiners to take the proceedings further. You can make it full screen. Dr.
Okay,
Siddhi.
sir.
Yeah.
Yes,
You
sir.
can make it full screen so that we can read it a little better. Yeah, okay.
No, don't
You
show
can
the
get
intro.
started,
Go to the
eh?
first.
Okay,
Is it
sir.
short,
Yeah.
short case
Am I
then?
audible?
This is a
It's a
short
short
Okay.
case.
case or?
It's a long case now.
Long case, sir.
Short case, no, all are short cases.
All are
Yeah.
short cases.
Okay, sir. So I'm presenting a case of 43-year-old female from Kozhikode who is a sweeper by profession. And informant is patient and her sister, and the information is reliable. Her present chief complaints were pain in both upper limb for past 17 years, exertional dyspnea, NYHA class 2 for past 4 years, worsening of dyspnea for past 4 months, as well as pedal edema for past 3 months. History of presenting illness: patient was apparently normal 17 years back. Her problem started with development of pain in bilateral upper limb, which was insidious in onset and gradually progressive. It was not associated with any trauma, no history of chest pain, dyspnea on exertion, syncope, pre-syncope, lower limb claudication, abdominal pain, or jaw claudication, headache, decreased urine output, blooding of vision, or any yellowish discoloration of eyes during that period. She was evaluated in Government Medical College, Calicut, and was started on some medications, probably steroid and methotrexate, elicited from her history. Following which she underwent a procedure via bilateral radial route 16 years back, following which her symptoms got relieved. But 2 years following that procedure, patient had recurrence of her upper limb pain, and she underwent another procedure via right femoral route, which according to patient was not successful. Following this, patient was lost to follow-up, and she was also not compliant to her medications. 4 years back, patient started complaining of exertional breathlessness with associated exertional angina, which was NYHA functional class 2. Patient was again evaluated in Government Medical College, Calicut, and she underwent coronary angiogram for the same 4 years back, which was normal. Patient remained in functional class 2 for next 3 years. 7 months back, patient developed fever, low-grade fever for 2 weeks duration. She was evaluated and later hospitalized and given IV medication for 6 weeks. Following this, patient was discharged with an advice to undergo double valve replacement surgery. Now, patient presented with worsening of dyspnea for past 4 months with associated orthopnea and PND. She is getting repeatedly hospitalized for the same in the last 4 months. And there is also a history of associated bilateral pedal edema and palpitation for last 3 months. There is no history of syncope, pre-syncope, abdominal distension, decreased urine output, no history of abdominal pain, blurring of vision, altered sensorium, or chronic cough with expectoration. Patient was planned for angiogram during this current admission for pre-op evaluation, but it was postponed. Patient was not able to lie down because of breathlessness. Past history: patient is a known case of hypertension for past 15 years, but is on irregularly on medication. There is a history of 2 procedures done for bilateral upper limb pain 16 and 14 years back respectively, via radial route for the first time, via femoral route during the second time. There is history of procedure done via right femoral route 3 months back, and according to patient, it was done for some abnormal enlargement of blood vessels, stenting of some abnormal enlargement of some blood vessel in the abdomen. Family history: she is born to a non-consanguineous married parents, and there is no history of similar illness in the family. Obstetric history: she is a mother to a 10-year-old daughter. There was no history of any antenatal or postnatal complication during the pregnancy, and there is no history of any spontaneous abortion or intrauterine death in her obstetric history. Personal history: she is taking a mixed diet with currently reduced appetite. Bowel and bladder habits are normal. So I would try to summarize my history. A 43-year-old female, non-hypertensive on medication, initially presented with bilateral upper limb pain, for which she underwent 2 procedures 16 years back, and she was lost to follow-up and non-compliant to medication. Now complaining with dyspnea exertion for functional class 2 for past 4 years, with worsening of dyspnea with associated orthopnea, PND, and pedal edema for past 4 months. This worsening of symptoms for past 4 months was preceded by an episode of prolonged fever requiring 6 weeks of IV antibiotics, and likely it could be infective endocarditis, for which she was admitted back then.
Yeah, I think it's a fairly okay history. What about the Srijitra Institute? Would you like to discuss what are the possibilities, or what is the physiological status that she is in, and what are the possibilities which has led into this pathophysiological status?
And sir, patient first developed symptoms at the age of 27 years in the third decade, and a female patient with history of bilateral upper limb pain, and she was a hypertensive also at that time. So maybe component of aortoarteritis, like Takayasu sir. And she has undergone a procedure through bilateral radial artery also, maybe subclavian artery, balloon dilatation or some procedure, sir. And over a period of time, she was not compliant to her medications, and she was not taking any medicine. Probably the disease
Again,
has progressed.
she had a re-procedure after 2 years, is it not?
Yes, sir.
Yes, sir.
So what was it?
Because her symptoms, he has mentioned that the symptoms has reappeared in the limb. So probably they were trying again, or trying to put some stent, maybe, or the radial arteries were occluded after the first procedure.
Okay.
And
Alright.
now the disease has got unnoticed and led to aortic dilatation and regurgitation, which is leading to breathlessness, orthopnea, PND. And this left heart failure has gone unnoticed and leading to right heart failure symptoms, sir.
Okay,
You
I'll
don't think
just
these
ask you one
symptoms are
question.
due to hypertension? Because aortoarteritis hypertension is the commonest, isn't it? What is the cause for hypertension in aortoarteritis, especially in the Indian setting?
Sir, in
It's
aortoarteritis,
renal
the
artery.
most common cause is renal artery stenotic lesions, as compared to fibromuscular dysplasia in other younger groups.
Okay, so it could be renal artery. It could be any other reason why this patient could have had
Baroreceptor cell, actually, carotid artery stenosis causing baroreceptor response to be blunted out.
I'm sorry, I can't follow. I was just asking what are the likely possibilities for a hypertension.
So,
One you said is renal artery stenosis, which is true in Indian setting. A lot of arteries have abdominal aortic involvement compared to what is described in the west or in the east.
Also, this
Yes,
sir,
carotid
this Takayasu arteritis is pre-atherosclerotic disease, sir. So because of atherosclerosis, the patient has become hypertensive. Arteries are not elastic.
So you mean
Yeah.
non-compliant arteries, is
Yes,
it?
sir. Yes, sir. Elasticity is lost.
and
Before that,
What is the cause of hypertension?
Renal artery is one.
Coarctation?
But could it be a
Sir,
coarctation or something like that?
yes,
Arteries can also present as, what is that? A coarctation like picture. Okay. Calicut, can you tell what are the things you might
Sir,
come?
possibilities for cause for hypertension in Takayasu. One possibility I've already mentioned, renal artery involvement.
That's
Second
okay.
would be, sir, involvement of carotid artery and decreased
I don't
coefficient
know
of
whether
RF
carotid
receptors.
artery can.
Carotid
I'm not
artery.
so sure. Basically,
Yes,
Cannot.
aortic regurgitation associated with Takayasu
anywhere
arteritis.
on the aorta, if there is a significant narrowing, naturally it's like a coarctation. There will be hypertension, upper limb hypertension, isn't it? How did you manage this hypertension? How did you evaluate her hypertension? She had both upper limbs severely ischemic, requiring attended
Whatever it is.
vascularization. Yes. And you said that she's been hypertensive for the last 16 years. So what was your mode of following her for her hypertension? Especially because she went through pregnancy, I'm sure you must have interacted with the gynecologist about hypertension management. Yes.
This hypertension is likely to be secondary hypertension. So I have to rule out.
How do you measure the blood
How do you
pressure to tell that she has hypertension? Both upper limbs are gone, no?
No, yes,
They're all ischemic. So that they cannot truly tell you the blood pressure. You get my point, isn't it? I mean, a simple thing. If you can't answer this question, then
Can you measure at least systolic blood pressure if all the pulses are absent?
lower limb pulses. Lower limb pulsation.
okay, that's an alternative. If there isn't any significant involvement of
lower limb is upper limb.
Yeah, if it is just type 1 or type 2, I have started it. What is type 1, type 2? And what is type 3? Where you may not
Type
be able
1.
to get a good central aortic pressure.
Type 1 is only aortic arches and branches involved. Type 2 is ascending aorta with aortic arch involvement. Type 2A is ascending aorta plus aortic arch, and type 2B is ascending aorta plus aortic arch plus descending thoracic aorta.
It's very rare that ascending aorta gets stenosed by aortitis, though theoretically everything is possible. Right? So the minute is a type 3 or type 2B, that descending thoracic aorta is involved, then obviously the lower limb blood pressure also cannot be reliable, isn't it? So it's extremely difficult to measure the aortic pressures in aortoarteritis, especially if the aorta is involved or any of the lower down. You have to be careful about this. Confidently telling that she had hypertension and she went through pregnancy, isn't it, 10 years back? Okay, that's one thing.
Sir, if a patient presents with bilateral upper lip pain, how can he be sure from history that it is vascular in origin? The patient
will be
has got upper.
a claudication pain, sir. So upon exertion, it will increase, and upon rest, it will decrease, and upon the limb immobilization, it will decrease, sir.
That is, of course, lower limb you can make out better, but upper lip?
Sir, overhead movement above the shoulder will increase the pain, sir.
Okay. Only the feeling of fatigue, arm fatigue will be there. There may not be full-fledged. Arm fatigue will be there, especially when the patient has. Okay.
So what do you think must have happened during that? Obviously, historically, it's fairly correct that it is gradual onset and slowly progressive. So could it have been a thrombus or an embolism, or do you think it is a progressive arterial narrowing?
Progressive.
It is fairly typical, isn't it? That it is a progressive arterial narrowing rather than embolic cause. And embolic cause bilateral, both upper limbs, is extremely rare. Thrombus, in situ thrombosis of an already diseased artery. That also is possible, but it should be more acute in onset. So for all practical purposes, that history 18 years ago, whatever it is, does suggest that it is an arterial involvement, two arteries, both upper limb. So how strongly you think it is aortoarteritis and no other arterial problem?
Predominantly upper limb involvement is there, sir. Female, young female.
Artery, which is the arterial segment which is more specific for so-called
Subclavian,
Takayasu or right?
Subclavian artery involved.
Bilateral
Subclavian is there.
subclavian,
Bilateral
Asian lady,
symmetrical.
Asian female, young Asian female.
Bilateral mid-segment, isn't it?
Mid-segment.
Mid-segment
Mid-segment.
subclavian. Okay. So mid-segment, does it involve the vertebral or it doesn't involve the vertebral?
That is a vertebral.
No vertical,
Doesn't
no
involve the
vertical
vertebral
involved.
Yeah, vertebral is actually the first segment, isn't it? Beyond the first segment, I presume is the second segment or mid-segment. But it could involve the carotid or the brachiocephalic also, is it not? Okay, so what do you think? Anything more you should ask?
No, fine. We'll go to the
Coming to the recent history, of course, we have to ask you because there has
Yes.
been a sudden worsening from a relatively asymptomatic stage for 14 and about maybe 12 years. Last 4 years, she has been having mild effort dyspnea, not.
Yes,
But
sir.
then the worsening has been probably due to a febrile illness for which she took medication for about 6 weeks. So what do you think must have happened?
So,
Yeah,
dyspnea.
not the Calicut people. Calicut people, we are probably more informed about the case than we. So you should be, you're part of us. Yes.
Sir, patient must have had a moderate AR in the past because of the arteritis, which might have progressed to severe because of the infective endocarditis. And also patient has been told that she will need a DVR. So probably even the mitral involvement has happened, probably because of the infective etiology, probably, sir.
Oh, you mean primarily aortic and secondarily mitral?
Yes, sir. Yes, sir.
Yeah, that's true. I don't think mitral valve is, I mean, if you read the literature, I suppose anything is possible, but basically it is aortic regurgitation. What are the other cardiac involvements related to arteritis?
Coronaries are involved, sir.
Yes, only
lesions.
coronaries when you call it as type 5 or type 6 and any other?
In which other disease you get osteal involvement of the coronary?
Sir, radiation.
What is it?
And
No, aortic you agree. I agree because of the aortopathy, there is aortic regurgitation. And you already said that it can have coronary involvement. Any other cardiovascular problems other than the peripheral arteries, what you said? What about the pulmonary arteries?
Sir, pulmonary embolism can be there because of, like, it's a prothrombotic state. So pulmonary embolism is a possibility, sir.
No, I don't think the pulmonary. I don't think the pulmonary involvement is due to pulmonary embolism.
No, sir.
It is probably the same.
In 5% of the cases in Asians, this disease can involve
the inflammatory involvement of the pulmonary
arteries.
It actually can cause pulmonary stenosis and that can cause some pulmonary hypertension. Yes.
Pulmonary hypertension.
The spectrum. So, how do you think aortic regurgitation infective endocarditis can affect secondarily mitral valve?
Can it affect?
Can it affect?
Sir,
if the LV has dilated, it can cause secondary MR, sir.
Oh, you think it is secondary MR?
Not a
ventricular MR, not atrial MR. Of course, today everybody is talking about functional MR as ventricular and atrial. So you think it's functional MR, not organic.
But involvement of mitral valve is also there in aortoarteritis, sir. So currently
it is extremely rare. So it is, as I said, everything can be involved, but it is extremely rare. Do you think this endocarditis could have affected the mitral valve?
Can the vegetation or the aortic valve also be there in the mitral?
Yeah, you do get that aortic regurgitation, mitral valve flutter, isn't it? If the aortic jet is towards the mitral valve. So to some extent, mitral valve can also be involved, though much less common, but possibly secondary to aortic, not primarily mitral. I would not consider primary mitral valve disease here, unless you're calling it as secondary mitral regurgitation due to annular dilatation or whatever reason. Okay. Vallabh, can you just, anything else you would like to ask?
So, what else do you think would have contributed to his worsening? Other than, of course, valvular involvement is one, secondary.
Second is coronary artery disease leading to ischemic cardiomyopathy and ventricular dilation.
So LV involvement also can occur secondary to.
Yes, sir.
Okay. Fine. We can go to examination or?
Yeah, I think so. Quickly.
Okay, sir. So clinical examination, patient is conscious, oriented of time, place, and person, moderately built and nourished, weight of 50 kilogram, height of 148 centimeter, BMI of 22.8. There is bilateral pitting pedal edema present. There is no clubbing, icterus, sinuses, lymphadenopathy. There is no peripheral signs of infective endocarditis, and there is no peripheral signs of aortic regurgitation.
No, sorry.
Pulse
That's
rate
what.
is 96.
What about peripheral signs of? No peripheral signs of aortic regurgitation.
Yes, sir.
Okay.
Okay.
Pulse rate is 96 beat per minute, regular rhythm, normal character, bilateral brachial and radial arteries are feeble. There is no radiofemoral delay, no vessel tenderness, vessel wall tenderness. Blood pressure in right upper limb is 106 bar 60 millimeter mercury, in left upper limb is 92 bar 56 millimeter mercury. Right lower limb, it is systolic blood pressure of 150 millimeter mercury, and left lower limb 160 millimeter mercury. Respiratory rate is 20 cycles per minute, abdominothoracic.
It is telling this
SpO2
mechanically no radiofemoral delay. This obstruction in the subclavian, isn't it?
Subclavian.
Yes, sir.
And you did
But the
mention about
pulse
the
is
subclavian. Is subclavian is
Pulse-
palpable, not palpable, involved? Brachial,
So
radial,
don't
okay.
expect some radial to femoral delay.
could not appreciate it, sir. Actually,
Radials
radial
are
also
palpable. Are the radials
yes, sir.
palpable?
Yes, it's palpable, but it's feeble in comparison to the femoral pulsations.
Okay.
And what about subclavian?
But just keep in mind, don't tell things mechanically. I mean,
Okay,
certainly if you have been treated 8 years ago for bilateral upper limb artery occlusion,
Yes, sir.
Lower limb
certainly
blood pressure is
there has to be
150,
some
sir.
delay.
Sir, lower limb blood pressure is 150. Shall we say that no peripheral signs of AR?
Because upper limb there is
That I do not know. You tell me if there is
Some hill
because the
sign is
pulse, the upper limit is only 50. Anyway, with blocks in the arteries, the peripheral signs may not be so evident, isn't it? So if you think the aorta is relatively free of disease, then lower limb pressure and pulse pressure might give you an indication. What is the diastolic pressure in the lower limb? You didn't take. You only took systolic.
Yes, sir.
That's fair enough, I think. Diastolic is not really reliable.
Right.
Okay.
What about carotids? Supposing I say I want to know involvement of carotids.
Carotid pulse were well felt, sir.
Carotid?
There was carotid thrill was there. There was well felt, sir.
Carotids well felt. Thrill?
Yes, sir. No tenderness. And no carotodynia was there.
Was there carotodynia? Yeah, that's basically you should tell that, because that's one of the important reasons for suspecting activity. Right?
How do you estimate a external carotid? I mean, field external carotid. Any method?
With the contralateral thumb, sir.
Where? External carotid, I must. What is the artery which is a branch of the external carotid, which is can tell you whether it's involved or not? The anesthetists always use that.
Temporal.
Okay.
The superficial temporal, no?
Okay, I think we'll go to the next so that you can tell us better about the arterial involvement. Go ahead.
Mean JVP is elevated, sir, 10 centimeter above sternal angle. There were 2 positive waves and 2 negative waves seen with normal respiratory variation. Cardiovascular system examination, inspection and palpation done together. Precordium appears normal, trachea central. Apical impulse seen and felt in 6th left intercostal space, 2 centimeter lateral to the mid-clavicular line. It was hyperdynamic in character. Pulsations also seen over epigastric region. There was a systolic thrill felt at the apex, and there was bilateral carotid thrill present. No other pulsations, scar or sinus is seen. There was no parasternal heave, and there was no any other palpable sounds. Percussion, river dullness was felt in 15th right.
You said pulsations in the epigastria. Now, there are 2 or 3 reasons why you get pulsations in the epigastria. I think from your side, you should be able to tell whether you thought it was right ventricular or you thought it was a hepatic pulsation, or you thought it was a conducted from the aorta, abdominal aorta.
It's conducted from aorta. I felt, sir. It felt on the pulp of the finger.
I think that you should be able to tell, isn't it?
Yes.
I mean, because there is no other way. It's only a physical examination that will tell you. Okay, go ahead. Systolic thrill?
Systolic thrill felt at apex and bilateral carotid thrill were present, sir.
Okay. Oh, so there is a systolic reflex. Okay.
Yes, sir. Lever dullness, percussed at fifth right intercostal space, confounded by tidal percussion. Left heart border corresponded to apex, right heart border corresponded to right sternum margin. Second left intercostal space was resonant. On auscultation, first heart sound was soft. Second heart sound was loud with loud A2 component with narrow split. There was LV, third heart sound present. A high-pitched pansystolic murmur of grade 4/6 heard at apex radiating to axilla and back.
Sorry, you're going too
Better heard.
fast.
Yes, yes.
You're going too
Okay,
fast.
sir.
If it was
Hold
normal,
on.
we had no problem. But you said second heart sound loud.
Loud.
Loud, sir.
Which
Loud
component is
A2
loud?
component. Loud
Aortic
A2
component and the
component.
pulmonary component.
Loud aortic component with narrow split.
Aortic component is loud and the
Loud.
split is
Yes, sir.
narrow, is it?
Yes, sir.
Why do you think it's becoming narrow?
The LV ejection time is prolonged due to AR, maybe pushing the A2 more later to the in the cardiac. So
There is a increase in the left ventricle ejection time, is it?
yes, sir. Yes, sir. Yes, sir.
So it's almost like
Or
a
can it be some
paradoxical split.
ventricular conduction problem, like a LBBB?
LVB.
Yeah, anyway, you should think of this, isn't it? Either electrical delay
Yes, sir.
or probably a prolonged. Actually, in aortic stenosis, we do get it because narrow split could be a predecessor to paradoxical split, isn't it?
Paradoxical split,
Paradoxical
isn't
split
it?
doesn't come overnight. The A2 will go later and later and then cross over the body. Okay, go
So
ahead.
if you
Let's
have
see
a
the.
loud A2, you got
There
the
are
point,
good
no? What
findings.
Dr.
Let's.
Tarakan is telling. If there's a loud A2, but there's a narrow split, think that it is on the way of paradoxical split.
That's correct.
So a
You have
high
an
pitch
NVS3.
Okay, sir. Yes, sir. And then there is a high pitch pansystolic murmur of grade 4/6, heard at apex radiating to axilla and back. Better heard with diaphragm stethoscope in left lateral portion with breath held in expiration. There is another high pitch soft blowing murmur, long in early diastolic murmur of grade 3/4, heard over third left intercostal space. Better heard with diaphragm stethoscope with patient sitting and leaning forward with breath held in expiration. There is a high pitch short ejection systolic murmur with early peaking, heard over aortic area with diaphragm of stethoscope with patient sitting and leaning forward with breath held in expiration. This murmur was radiating to both carotids. There is bilateral subclavian bruit heard, systolic bruit heard over epigastric and interscapular region.
What do you think this bruit over the interscapular region? You think it is due to collaterals or you think it is due to obstruction in the aorta? What came to your mind? You heard a bruit on interscapular. No, it was not over the spine, you said. Huh?
Yes, sir. Could
Yes.
be due to collateral formations.
Collaterals, is it?
Collaterals.
Scapula is a very important location
Yes.
for collaterals in this.
Why? Why collaterals are not there in aorta isn't there? It's present in coarctation. What's so different? Yes.
Sir, because of osteal involvement in
Yes, aorta actually involves the ostia of the
osteas,
intercostal
so
artery.
collaterals
Right?
cannot form.
Yes.
So when you hear a murmur at the back, how
Whenever
will
you
you
get a murmur
distinguish
over
whether
the
it's
back in
coarctation or
aorta,
it's
it is due to
aortoarteritis?
originating
That
from
is-
the aorta.
Yes, sir.
Okay.
So
Systolic bruit over.
Gastrointestinal
I don't know why you
system
should say
examination.
systolic bruit. You know, bruit actually
Well-
being vascular. Don't use the word systolic. It's not necessary.
Okay.
Correct, because it does occur after a time after the ejection, because
Yes,
the flow has to reach that, or the pulse velocity has to reach there, so there is some delay, and it will always spill into the diastolic,
Diastolic,
right?
yeah.
So don't say systolic only. Just say bruit.
say
I think
bruit.
that is much more accurate than telling it is systolic.
But
All
actually,
vascular murmurs tend to be more continuous, right? All vascular origin murmurs tend to be more continuous. Obviously, they are more intense during the ejection. So the systolic component is always a little more louder, generally, except some occasions. I mean, that I don't want to discuss here. Okay, come.
and
So
when you're
just say
looking for the
bruit.
bruit,
Isn't it? Why
always
it's
look at
systolic?
the interscapular and infrascapular area.
Bruit.
If it comes
Yeah.
down the spine, which has been already mentioned, it's more likely to be aortic, or it will rule out coarctation. Coarctation will stop at the interscapular area. Okay.
Now, what you said, hypertensive retinopathy changes.
Yes, sir.
Okay. So
Right.
usually in Takai's arthritis, what is the classical description of
Wreath-like.
what is it
Like
due to? Is it due to
What is that
hypertension or due to
wreath
something
like
else?
is due?
Sir?
What is that wreath due to?
The wreath is due to what?
Focal hemorrhages, sir.
Oh, focal hemorrhages,
No.
my God.
Wreath is a anastomosis, no? When you
Yes,
say wreath, it's an
anastomosis occurs
anastomosis.
only when there is ischemia, right?
Yes.
So it is related to renal artery ischemia, right? That is a wreath formation. That is what was described in maybe, I don't know, 1990s,
The
16 or whatever.
ophthalmologist
Okay, go
described
ahead.
it.
Okay, sir. From the
Yeah.
history and clinical examination, my clinical diagnosis is occlusive arterial disease affecting bilateral upper limb vessels, large vessel vasculitis, Takai's arthritis, probably in active phase clinically. There is severe mitral regurgitation, moderate aortic regurgitation, clinically pulmonary hypertension, status post peripheral angioplasty for peripheral occlusive arterial disease for upper limb claudication pain with probable restenosis on both sides, probable EVAR for descending aortic aneurysm, treated infective endocarditis 7 months back, decompensated heart failure currently in sinus rhythm, New York Heart Association class 4.
Okay. So how did you say pulmonary hypertension? You have not mentioned clinically, you have not given
Sir,
evidence
actually,
of pulmonary.
patient having signs of clinical features of AR with signs of severe MR, still having a narrow split.
But narrow split you said was
Yes,
due
sir.
to aortic
Due to,
phenomenon going towards the pulmonary,
pulmonary, no?
not the
It's not-
pulmonary coming towards the aortic. But anyway, it's good. I mean, we also do not know why that is close. I quite agree with you. But the patient
could
who has
be
been in heart
P2.
failure, initially maybe PNT or something, followed by heart failure, basically has some form of pulmonary hypertension, isn't it, with right heart failure? So there will be pulmonary hypertension. So it may not be clinically so evident because you said second space is dull, resonant to percussion and all those things. Just keep it in mind. Don't have too many disparities in your descriptions. And why do you think it was descending thoracic aortic repair, not an abdominal aortic?
Actually, a patient's description was like it was done for some abnormal enlargement of vessel in the abdomen.
I mean, anyway.
So it can be.
Yes, probably.
Okay. Let's go ahead.
Sir, patient adds a third heart sound, sir. So shall we keep aortic regurgitation as severe or
No.
because both MR
in
and
isolated aortic regurgitation, if you have a third sound, it is either acute AR or chronic severe AR or LV dysfunction AR. Right? Three.
Yes, sir.
But if there is mitral regurgitation, then it can be a flow third sound. But he hasn't said an MDM, but it can be LV dysfunction third sound, even if it's an MR, if there is no mid-diastolic murmur. Right? I would agree with you that a loud S3 with absence of a mid-diastolic murmur, which he didn't mention anyway, regardless of the aortic regurgitation, there isn't an ostensible murmur also. It could be LV dysfunction. But it cannot be due to aortic regurgitation alone because there is severe mitral regurgitation.
Yes, sir.
And he already said that the apex is actually hyperdynamic. Hyperdynamic favors more mitral regurgitation, but I think it's a mistake. I'm sure it must not be. It must be a bit of a forceful apex because aortic regurgitation with hypertension would also cause some left ventricular hypertrophy. Hypodynamic is typically seen only in mitral regurgitation or ventricular septal, where there is no left ventricular wall thickening or hypertrophy. Okay. In aortic regurgitation, invariably, there is a little sustained quality, but then we are afraid of telling a little sustained in regurgitant lesions because it has been pushed into us. The regurgitant lesions, hyperdynamic. It's absolutely not correct. You just go and see the patient again. I'm sure you will appreciate how that apex is sustained for at least more than 2/3 of the systole. That's besides the point. Okay, next. So I think what do you think what about the carotid involvement? You didn't mention anything because there is
no carotid involvement or subclavian, you said.
Carotid.
Subclavian Burri was
Only carotid involved.
The real was.
I don't think carotid are involved. You said
No, sir,
activity.
no.
What is the reason for activity? There is no carotidynia. There isn't any constitutional symptoms. All the symptoms are due to hemodynamic heart failure.
Patient is having a worsening of symptoms like fatigue. Now the symptomatology in clinically also patient underwent EVAR. In history-wise, patient went to some intervention, following which now having symptoms of signs and symptoms of some obstruction in the
Realize,
form of bruise.
generally no interventions are done in arthritis when there is activity. Activity has to be controlled before interventions are planned elective. Maybe an emergency intervention can be done, but elective interventions are never done till the arthritic inflammatory symptoms are controlled. Right? That's a dictum. Okay, next. Go ahead.
This 12-lead ECG, sir. Patient is in AC sinus rhythm. Axis is normal axis. There is LV left ventricular hypertrophy with strain pattern, mostly volume or pressure overload strain pattern, with the T inversion in one AVL as well as ST depression in V4 lead. LVH with pressure overload strain patterns.
LA enlargement?
LA.
Yes, sir. LA enlargement Morris index is more than 0.4, sir.
PR interval is also around 200, sir, first degree.
Yeah.
We can make out from here.
And axis?
Okay,
Normal
so
axis, sir.
Okay.
So what does this ECG tell you because of your hyperdynamic apex and LVH with strain pattern?
Sir, in case a patient having both MR and AR, it should have been a volume overload LVH, but it is having a pressure overload because of a long-standing hypertension. Patient is already was having
Possibly, yeah.
pressure
So it
overload
has to be
for
either
long.
hypertension or LV dysfunction. Right? Okay, go ahead.
What is the other ECG sign of
Oh,
LV
sorry.
dysfunction if aortic valve is involved?
Sir, if aortic valve,
What?
Sir?
How would you say that there could be LV dysfunction on the ECG? I mean? What is this STT changes are there?
poor progression of R.
Brody's
No.
effect will be there, sir. Volume, QRS complexes, voltage will be long.
Yeah. The other thing is that there will be slight widening of the QRS complex.
IVCD will be there.
Okay, quickly. I think we have only 5 more minutes. With
chest
Harikrishna's
X-ray.
permission, we'll extend it to 5 more minutes. Yeah, go ahead, quick.
So chest X-ray AP view and lateral view. AP view showing that there is prominent cardiomegaly with LV type of apex. There is a aortic knuckle is prominent with obliteration of pulmonary bay, and there is enlargement of L appendage as well as right atrial, and there is shadow and shadow appearance also left atrial enlargement with increased vascular marking suggestive pulmonary venous hypertension.
Fine.
And there is a stent across the
aortic arch knuckle. What is it? Is there some shadow there?
yes, sir. Probably
what is it?
stent of EVAR.
Okay,
EVAR
there's a stent. All right. And don't be very emphatic on left atrial appendage in non-rheumatic mitral regurgitation, right?
Okay.
People might unnecessarily spend another 5 minutes asking you. In rheumatic mitral regurgitation, because of atriopathy, you can have left atrial enlargement. In others, just look for left atrial enlargement, right? Okay. No, maybe there is left atrial appendage.
And what does the lateral view show?
Okay, go ahead.
Lateral view saying obliteration of retrosternal space, RV dilatation.
Yes.
Yes. Okay.
Blood investigation was unremarkable, except there was LDL of 203.
Only positive ones. Only positive things you should tell us.
ASR was high, sir, 54 with NT-proBNP 800, sir.
CRP also not very high, 7. Okay.
7. Yes, sir.
Yeah.
Echo, sir, LA was enlarged 38 mm. Aorta was only 19 mm. LV diastolic diameter was 51 millimeter and systolic was 29 millimeter with ejection fraction of 72%. Good LV function, concentric LVH. There was severe MR with probable perforation of AML, moderate AR and no PH. There was increased gradient noted across descending thoracic aorta, gradient of 72 millimeter mercury.
Fine.
Increased gradient across? Sorry.
Descending thoracic aorta, sir.
Okay, okay. Are there any
Okay.
vegetations? Only
Sir,
perforation.
yes, I'm coming to it. Sir, this was echoed and during the history of prolonged fever, suspected infective endocarditis. You can say there is a gross concentric LVH with thickened septum and probably some severe
Okay.
MR could be seen. Significant MR could be seen in this view, parasternal long axis view.
He is
Next.
enlarged in plaques.
Yeah,
Yes,
it's severe MR because even the pulmonary veins are getting.
Yes, sir.
they are going
Okay,
into the
next.
pulmonary vein. Yes.
We proceeded with transesophageal echo. In transesophageal echo, you can see some vegetation attached to the mitral leaflet as well as perforation of mitral intermitral leaflet near the base with associated severe MR.
Okay.
There was no
Really?
significant. The LV function was good. There was no regional valve motion abnormality.
Fine.
This is a pre-procedure and post-procedure TVAR image. Patient had a large aneurysm of descending thoracic aorta. Embolism was about to rupture, which procedure was done under emergency situations.
Good.
Fine.
This is a 2D echo during current admission, sir. Here also, one thing I want to point out, sir, aorta is not dilated, but as we can see, the thickness of aorta, aortic valve is more in comparison to normal person. So it could be a possibility sign of some kind of aortitis, active aortitis in the patient.
Thickness, sir.
Also, there was no RWMA and there was good LV function. The severe mitral regurgitation was present, as
Yes.
well as moderate AR with pressure half time of 274 milliseconds.
Okay.
There was murmur in clinically. There was a ejection systolic murmur, but there is no significant.
Oh, that is not
AS.
expected, isn't it? That is a flow
Yes, sir.
murmur because of moderate
Yes, sir.
AR. And the aortic valve and annulus is not very much dilated. So there will be some
Yes, sir.
functional murmur. Right
Sir,
side
left
normal,
atrium
right?
is not left atrium is not enlarged, sir.
Right atrium is enlarged.
Left atrium is enlarged.
Quite enlarged.
30.
Yeah. There it is.
Ejection fraction by AL method is 55%, sir. And this is a gradient. We got a gradient of around 72 millimeter of mercury across descending thoracic aorta.
Okay.
So final
Obviously,
diagnosis.
there was no way of knowing what is the central hypertension because
Yes, sir.
then arm vessels are involved as well as the aorta is involved. So he obviously has central hypertension. That must be the reason for that severe hypertension, hypertrophy of that. Can't be explained by
You have some
MR
CT
alone,
image.
and it cannot be truly explained by AR as much. Okay.
What about some CT images of the lower, that is the renals, IDX, etc.?
The image
No.
could not, it didn't include, sir, but report was saying that there was no renal artery involvement, sir.
Okay.
Yeah.
Which artery
Sir,
is not involved in aortoarteritis?
Pulmonary arteries, sir. Usually
Pulmonary
they say.
arteries is involved quite a bit nowadays. Something
Inferior
in the
mesenteric, huh? Is it? I don't know.
inferior mesenteric.
The Japanese used to say inferior mesenteric is rarely involved, and instead they would say that infrarenal it's very rarely involved. But then the Indians said,
in fact, it can meander.
yeah,
and
they have
give,
added
give
on both descending, infrarenal aorta as well as the iliacs.
Some
Okay.
people call it the artery of Drummond. They say. Okay.
Final diagnosis, sir, occlusive arterial disease affecting bilateral upper limb vessels, large vessel vasculitis, Takayama arteritis, probably in active phase clinically. Severe mitral regurgitation with sequel of infective endocarditis with AML perforation. Moderate aortic regurgitation likely due to aortitis. Status post peripheral angioplasty for peripheral occlusive arterial disease of upper limb with probable re-stenosis of both sides. Status post EVAR for descending aortic aneurysm. Probable re-stenosis inside the stent graft. Treated infective endocarditis 7 months back. Decompensated heart failure, systemic hypertension, hypercholesterolemia, probable familial heterozygous hypercholesterolemia, does lipid network criteria fulfilled. Sinus rhythm,
To say
patient
central
sinus rhythm.
hypertension because you have no way of finding out dietary pressure except by cardiac catheter, right?
Yes, sir.
Or if the carotid was not involved, then you could have taken it from the carotid. Otherwise, difficult. Okay. So what's the plan of management in two minutes?
Then in this
This is
patient,
activity
currently
control.
Yeah,
Yes.
two issues, isn't it? One is hemodynamic, the other one is activity of the
Activity
disease.
control.
Activity.
For activity, we have done CRP, which is just borderline 6, I think is not very high. ESR, of course, in a female, maybe.
54 is also not so high.
Yeah. What is the medication she's on Calicut Medical College?
So currently she is taking currently on IV IV furosemide.
No, not
As
decongestion.
well
No.
as
I'm talking about the
immunosuppressive
disease
is on
modifying
activity.
drugs for aorta
Activity.
arthritis.
she was on steroids and methotrexate, sir.
Okay, steroids with methotrexate. Okay. So obviously she's being treated for activity.
So what will you
So
do now?
acute
So
management is, of
currently
course, decongestion with diuretics, obviously. Yes.
second is we have to do a coronary angiogram for this patient to rule out any coronary artery involvement. Prior to patient is planned for dual valve replacement surgery. Prior to that, a coronary angiogram as well as check a pressure gradient across that to rule out any kind of restenosis of the EVAR stent, sir. Since we got a gradient across that in echo.
Yes. I don't think we are concerned about coronaries now at this point. It's already been done once, isn't it? It has been reported as normal.
One was normal, no?
Very unlikely that there.
That DTA gradient, there was no diastolic tailing, sir. So shall we consider it in that?
Not, that's what, that also doesn't look very significant, that EVAR gradient.
Follow.
Important thing
Please
is
follow
to
your
go for a
question.
DVR as quickly as possible.
The color Doppler which he showed, there was a gradient was there in the DTA, but the diastolic tailing was not there.
Agreed.
Oh, you don't bother about diastolic tailing. I think it's a very artifactual and subjective. Leave it. I mean, I know you can use that word diastolic tailing. I find it very confusing. Okay. So I think anyway, the patient should probably continue on the activity medications for arteritis. And for the hemodynamic purposes, I don't think we can settle only with mitral and aortic. You'll have to also consider the aorta
DVR.
itself. It's going to be a very major issue unless the whatever the endovascular passage that has been used, it can be dilated again. To usually they may have underdilated it or something like that. That can be seen. Vala, what do you think? You are more familiar with these.
Actually, DVR is a thing, but the problem is the activity. And since we feel that the activity is not too
DVR
much, you
is not
should
the
not
answer
wait
because
also.
there is almost 70 millimeter gradient across the
And
aorta.
you must
Obviously, that
attend
has
to
to be
the
tackled, which I
EVR
think
also.
can be done with a balloon. I don't know why it was not attempted.
You can just do a balloon dilatation of that segment and
I
see.
think it's lost, isn't it? There's already a scaffolding there. You only have to just modify the intima or whatever the intimal proliferation. Because it's just 3 months. It may be just a thrombus or something like that. Okay.
But the surgical thing should be a little faster.
Activity medications and decongestant drugs. There's nothing new. Certainly here it's difficult to manage because central hypertension cannot be monitored unless the carotids are totally normal. And in which, even there it's possibly not non-invasive measurement of blood pressure from the arteries is recommended. It's been told, but I never used it. I'm not aware of it also. Okay.
They try to do it with pulse waveform, but it's not accurate.
Certainly, you need to monitor central aortic pressure. Shall we hand over the case, session to you?
Yes, sir.
Yeah.
Over to Dr. Jyoti and Dr. Arun for taking the OSCE forward. Thank you, Jeeman, once again.
Good evening to all. So, shall we start? Vinay, are you there?
Yes, yes.
Yeah.
Vinay is there. Please go. Yeah.
So, this is primarily not spotters. These are questions which we will show, and there will be multiple choice questions, and the person who answers maximum in the shortest time wins. So, for this, we need to read the questions very carefully. Questions are simple, but it may not be very straightforward. So there will be a 60-second timer for each question, and ensure to answer before the timer runs out. So how we can join? They can see a screen, right side there's a QR code. You can take your phone and the camera you can on and log in. Or you can go to mendy.com and put this passcode that you can see on the right side. So you can, all of you can join by now. So we'll wait a couple of minutes for everyone to join. So there are no negative marks, and make sure you have a very good internet connectivity. And don't receive any calls in between because you are using your phone also, so that can interrupt your connectivity. And in case your screen gets frozen, there's an option to reload. You can just refresh your browser and rejoin. Do not close this Zoom window because you will not be able to listen. So just minimize or switch it to browser to join Mendy. But if you are using a laptop and a mobile, that's the best scenario. You can see through the desktop or laptop, see the questions, listen to what is being told, and you can answer through the mobile. In the mobile, if it is images, you can zoom and see it very clearly also. So the aggregate score through an algorithm using the fastest finger along with the correct answer will be considered by a system to determine the final winner. And don't forget to enter your full name as registered name to receive the prize.
Is enter your name which you have registered. Don't enter any nicknames or something. You will not get because we have to contact you for the prize.
Yeah, so we will just wait a couple of minutes for all of you to join. So you can use that QR code in your phone camera and scan it and join the link and give your name, or go to mendy.com. So we'll wait a couple of minutes for all of you to join.
So those who have joined from mobile, do not worry. You can also join. You just need to go open your browser, type this thing, this www.mendy.com, and enter the 8-digit number that is displayed. And you will be seeing the question, everything on the browser. Just ensure that the zoom is minimized and kept somewhere. That's all, because we want to hear the volume. That's the reason. The voice comes from Zoom, but you will be interacting. The questions and the answering, everything will be on the browser.
Someone has mentioned that you didn't find the column for name. You can just log in using this QR code again. You will find the option to name once we start it.
So in the next slide, there will be name. The next
don't worry, it will come. It will come in the next slide.
So till now, 68 people have joined. We will wait a couple of minutes for all of us to join.
It will say all is set or you are ready to play. So don't worry.
Now the name screen has come, so you can enter your name.
You can enter your name and be ready. So we will be showing the questions. Questions are actually a very short question with the accompanying image or video, and their answers will be in a multiple choice question, and the best answer should be answered. And once you answer that, you will not be able to try again. That will be locked for, and the shortest time is taken into account. And you will not be able to go back also. We will wait for a minute more.
There are 25 questions. The first question will be a trial.
This is next is a trial. What you will see a trial question to interact with the interface, and then we will go to the real quiz. So, Hari sir, once you tell, we can start. Maybe.
Yeah, I think 58 people are ready, but there are around 100 attendees. So, shall we? If anybody finding any difficulty, you can tell us. We can just give the instructions. Any difficulty you face, you can type it in the chat box. But this is the first time we are doing, so
I think it's okay. So maybe several people have joined from two systems, so that's the duplication may be there. So I think we can probably proceed.
The best will be to join from the laptop and use the mobile to scan the QR code and start answering in the mobile and see the questions in the laptop. You can see the larger screen. Name is in the screen which had come. You can enter the name in the Mendymeter, mendy.com.
It will come in your mobile itself.
Yeah.
If it has not come till now, it will come in the next screen.
I think we can go forward, sir.
Yeah, I think we will start now.
Yeah, so we'll start with the trial question. So you can
Yeah.
see how it comes. So let's start with the first question. So you can see an image there. So identify this famous cardiologist. So this is not for marking. This is to get accustomed to the interface. So the right answer is Willis Hurst. So shall we move on to the real quiz? Ready? So let's start. First question, please. So we can see this ECG. It's a 50-year-old male with recurrent heart failure and a normal coronary angiogram. So let's see this ECG for a few seconds and then we'll go to the next slide. So can we go to next slide? So shall we have the question? So you can see an echo loop also. You have seen the ECG. So what is the next best step of management? Time starts now. Time finishes once everyone has answered or the 60 seconds finish. Please don't answer in the chat because you have to choose from the options given. So Dr. Deepak George just asked for a cardiac MRI, but there is no option to give that here. So you can answer one of those options. And no need to tell in the chat because they won't fetch any points. You have to answer in the app only. You have to use select one of the options. We'll show the answer and we'll proceed to next question. Yeah, so the right answer is GDMT because we can see that there was a LBVV and dysynchrony is also there with the severe LV dysfunction. CRT is obviously required, but after GDMT only. So the next best step of management is medical management only, GDMT. Let's go to next question, please. So you can see a echo loop on the left side. Watch the echo loop. We'll have the question right now with the options. A 65-year-old male with breathlessness. What is the next best step of management? So we have to select from the options. The time starts now. Thirty seconds more. So everyone has voted. So let's see the answer. So the correct answer, maximum people have chosen, it is CTPA. So you can see the classical McConnell sign in the echo loop. So you can see the apical hyperkinesia with the RV mid hypokinesia or akinesia. This is a classical McConnell sign. You should suspect a pulmonary embolism. Shall we move to next question? So a 40-year-old man with heart failure and syncope. This is a biopsy histopathological examination from a mediastinal mass. So shall we show the question? So what is the diagnosis? You can see the histopathological section here again. Very classical. So time is up. Let's see the answer. So most of us have answered correctly. It's a sarcoidosis. So you can see that granulomas and the classical multinucleate giant cells. It is actually called a Langhans type giant cell because there are two types of giant cells. That is foreign body and Langhans. So Langhans is a clear arcuate arrangement of nuclei is a classical of this condition, and it's a classical of sarcoidosis. Can we move to next slide, please? You can see the ECG here, and it can be seen and zoomed in your mobile also. So let's see the question. 30-year-old with the exertional dyspnea. What is least likely? So you can see the diagnosis and then think what is least likely with this. You have to take the best answer. So most of us have answered correctly. So this is actually ECG of a regularized atrial fibrillation ECG. You can see, in fact, it's not atrial flutter also, but most appropriate answer is none of the above. So the atrial fibrillation with a complete heart block is actually called atrial fibrillation, and it's a regularized atrial fibrillation. So when you see a regularized atrial fibrillation, you should think of a complete heart block, or it can also occur in the paced rhythmic atrial fibrillation also. Can you go to next slide, please? So there's a fluoroscopic image you can see. So just go through that image. Meanwhile, we'll see the next question with the options. So 80-year-old man with the dyspnea underwent following procedure. So from this procedure, you have to retrospectively think what we would have had. So he may have suffered from all the conditions except. So time is up. Let's see the answer. So that's correct. So it is not VT. Why? Because you can see this image. There is a transcatheter aortic valve situated. This is an RIO fluoroscopic view. There is a atrial lead as well as a ventricular lead and a LV lead also. So you can see there is a ventricular lead. In fact, there is a lumenless ventricular lead for left bundle pacing, and there is a bipolar screwing CRT lead also. So this patient would have had a possibly a severe AS, maybe a heart block, maybe a LBBB, but there is no ICD lead. So VT is the right answer. So all conditions except. So can you go to the next question, please? So you can see a ultrasound image. So let's go to the question. Which diagnosis is least likely? So what all differential diagnosis possible if you see a IVC or liver ultrasound like this? Okay, time is up. So I think many people have liked this question as well. So the correct answer is PAPVC. So it is least likely. So this is actually the Playboy bunny sign or the dilated venous hepatic veins seen in congestive heart failure. So this can also occur in RV cardiomyopathy, pulmonary hypertension, severe MS, dilated cardiomyopathy. So it is unlikely. It is not PAPVC. It is a Playboy bunny sign or dilated hepatic veins, which is a usual. We can find it in congestive cardiomyopathy. Can you go to next slide, please? So you can see a still image. You can see that appears to be a TE. There's an angle also written. So you can see what is there. So 50-year-old male presented with heart failure. What is the next best step? You can answer quickly also. So I think this is one of the easiest questions, I presume. All have answered. So this is myxoma. So the right answer is surgery. So let's go to next slide. Maximum people have answered the right question. Let's show the next question. The case of heart failure with a normal coronary angiogram. What is this procedure? We need to identify the procedure, ongoing procedure from this fluoro VD. We have the options. The time starts now. Let's go to the answers. So this case is heart failure, and most people have answered correctly. So most likely would have had a tachycardiomyopathy due to AFib, which is a class 1 indication for AF ablation. So this is cryo balloon ablation for atrial fibrillation. You can see the cryo balloon and EP catheters. So can you go to the next slide? So see the fluoro. What is the most likely diagnosis? Let's go show the options. Time is finishing. Let's see the answers. So this is EMF. So this is the classical clenched fist appearance on the RV angio. Can you go to next slide? What is true regarding this video? So we'll see the options now. Select the most correct, almost most appropriate answer based on what you see. So all has voted. Let's see the answer. Can you go back, please? Show the answer. Yeah. So it's a intracardiac echo-gated septal puncture or ice-gated septal puncture. You can see the septal tending. So this is used to gate septal puncture using intracardiac echo. Can you go to next? So a 30-year-old male with the homocysteine levels of 15 millimole per liter and recurrent CVA. So what is echo finding? So you can see that there's an angle given. So this is based on that is possibility. This is written the probe also is a T. So let's find out what is this echo finding. Can you show the options? So let's see the answer. So this is a 90 degrees, a bicable view for interatrial septum. So this is a PFO. You can see the PFO, which is not exactly as a hole. It appears like this, and you can see some blood traveling across the hole also. Let's go to next slide. So you can see this ECG. So you may be able to zoom it through your mobile device also. So let's show the options. So the 3-year-old with the LV dysfunction and heart failure. So which is least likely with this ECG? So with this ECG can have a couple of differential diagnoses. All of them are possible, but which is least likely with the scenario and the tachycardia or whatever the ECG pattern? So time is up. So we can see that ECG is showing a tachycardia which is breaking and reinitiating, which is a feature of atrial tachycardia and sometimes PJRT. and the inferior leads are showing negative P waves. That also indicates a possibility of a low atrial rhythm or a CSO-SAT, or even PJRT can also have the rhythm. So AVNRT is least likely to present with the LV dysfunction in pediatric population. So shall we move to next question? You can see the X-ray image carefully. Can we have the question? So which type of patient is most likely to benefit from this procedure? So let's see the answer. So this is something called a semi-permanent pacemaker or temporary permanent pacemaker. So you can see this pacemaker is not, this pulse generator is a single chamber pacemaker. The lead is there in the RV, and this pacemaker is not within the body. In fact, the pulse generator is outside the body. So it is a alternative to a femoral temporary pacemaker where you can keep it for a longer time. So answer will be a recurring myocarditis with AV block will be an ideal scenario, or CAD infections where you can actually keep a prolonged time temporary pacing, and the patient can also walk, move around with this. So let's go to next slide. The 3D image. 50-year-old man presented with heart failure and atrial fibrillation. So transesophageal echo was done prior to cardioversion, and this is a view from the left atrium. So you can see this, and what is the next best step in the management? I'm telling you, this is a view from the left atrium. So let's see the options. What is the next best step in management? Patient with atrial fibrillation, plan for cardioversion. So you can see there is a clot in the left atrial appendage. So patient should get an anticoagulation first. So let's see the next slide. This is an infant with the heart failure. What is the diagnosis? So there's a CT image. There's an echo image is also there. So both should be correlated to make the diagnosis. Can we see the options? So after this, we will see the results. So this is actually coronary cameral fistula. So you can see the CT with a dilated left coronary. So this is a coronary cameral fistula from the left coronary to RV. So shall we see the score right now? So Dr. Dinesh Raja is leading the scoreboard. So shall we go to next question? So there is a fluoro video here. History of shortness of breath. What's the diagnosis? So can we show the options? So let's see the answer. This is a yellow view. This is hypertrophic cardiomyopathy. This is a classical midventricular HCM. So we can see what you see is actually the apical aneurysm in the angio. You can see an ICD lead also in this. So it's a classical midventricular hypertrophic cardiomyopathy. Let's move to next slide. A case of mitral stenosis, now presented with the dyspnea. What is the next best step in management? Let's show the options. So if you want to see the ECG, you can zoom it also in your mobile. So the time starts now. So the ECG, you can see there is a no clear P wave. So it's atrial fibrillation with a relatively slow heart rate. And what is classical is you can see that ST segment is having a reverse tick or a scalloped appearance. This is classical of digoxin toxicity. It's also known as, everyone will be familiar with the term Salvador Dali Mustach sign. So that is based on the name of Salvador Dali, who was an artist. He was an artist who actually marketed his mustache. He has written a book also called Dali's Mustache. And if you Google Wikipedia, you will see his signature also. That is also looking like a mustache. So this is nothing but digoxin toxicity. So let's move to next slide. Can we have the question and options? We can see a fluoroscopic image. Identify the marked hardware or identify the marked structure. So many people answered correctly. It's an implantable loop recorder. In fact, many people answered it's a micro leadless pacemaker, but it is not leadless pacemaker. It is outside the cardiac shadow. So let's go to next slide. So you have to correlate with this ECG and echo image. So I didn't include a loop here, but this image itself is classical. So 66-year-old male with shortness of breath. What is the diagnosis? The classical case. Options. So many have answered correctly. So this is classical of amyloidosis. ECG, you can see very low voltage complexes, and there is Q waves in the anterior chest leads, and you can see the echo. It's a glistening appearance with the biatrial enlargement and LVH. This was also showing a relative apical sparing also, but that is not seen in this. So this is a classical of amyloidosis. Can we move to next slide? So this is also an image, but it gives enough information. So case of heart failure post myocardial infarction, what is the most appropriate diagnosis? The VU is written on the image itself. Let's show the options. I think many are ready to answer very keenly. This is classical image. Time starts now.
Vinay, can you show the leaderboard now?
Sir, it will come in the last now.
Yeah.
Just...
So I think the
Okay,
right.
it's okay.
Yeah.
Please go ahead.
Yeah. Right answer is ventricular septal rupture. You can see the plaques image where the septal rupture with the turbulent flow there. So let's go to next slide. Identify the marker structure. So you can see a 3D image on the left side. The same transesophageal echo image is on the right side also. So identify what may be the procedure. So what is this marker structure where the catheter is pointing to? Let's show the options. So this is left atrial appendage. When you have answered correctly, so you can see that this in fact one type of left atrial appendage called a bifid left atrial appendage, which is difficult to do a left atrial appendage closure in this kind of, or a veil fin appendage. So it's very difficult to do a left atrial appendage closure. So the T image is classical. You can see that it is pointing towards the left atrial appendage. So right answer is left atrial appendage. So let's go to next slide. So a 60-year-old woman with heart failure and syncope. So let's correlate this X-ray, what patient may have had, and we will show you echo video also. So can we play the video? Let's show the question. Time starts now. 60-year-old woman with heart failure and syncope. What's the diagnosis? So if you want to see the X-ray or image clearly in your mobile, you can actually zoom it. So let's see the answer. So many have answered correctly. The sarcoidosis. So echo loop, you can see actually the basal septal thinning is there with the scarring. That is classical of sarcoidosis. There is LV dysfunction. There is dyskinesia, basal septal thinning, and the X-ray is showing a CRTD. You can see an ICD lead, see a LV lead. So this is a CRTD. So patient had an arrhythmia, possibly tachyarrhythmia, and basal septal thinning with LV dysfunction. Your diagnosis will be sarcoidosis. Let's go to next slide. A 40-year-old male with the dyspnea and ejection fraction of 45%. What is the next step? So this echo, this loop is not moving, but it is, I can tell you this is a hypertrophied ventricle with an asymmetrical septal hypertrophy with an ejection fraction of 45%. You have the ECG. There are two strips. Let's see the next question. So what is the next best step in the management of this patient? Let's show the options. We can correlate all these images and decide. So we had the right answer is CRTD. So the answer is we had a patient with LV dysfunction. We picture like a hypertrophic cardiomyopathy, LV dysfunction. We had shown a strip which has got a wide complex tachycardia, run of wide complex tachycardia, and the ECG was showing complete heart block. So you have AV block, which requires more than 40% pacing when you put a pacemaker. You have an AV block, you have a tachyarrhythmia, you have LV dysfunction. So all these, the management will be not a simple pacemaker. This is you require a CRTD for such a patient. So let's go to next question. A 50-year-old with acute chest pain. What is the diagnosis? It's a straightforward question. Let's show the option. So we will have two straightforward questions at the last. There will be one more question only. So let's see the image carefully. 50-year-old with acute chest pain. What is the diagnosis? So that's the right answer. So you can see a saddle embolism. You can see the pulmonary artery bifurcation in the CT, the saddle embolism sitting there. So this is pulmonary thromboembolism. Let's go to next, our last question. 70-year-old male with a history of chest pain. So diagnosis is obvious. Let's show the options. So the fastest finger gets the prize. Time starts now. Options. So I think it is going very fast. Any likes also? Yeah, so that completes it. So the right answer is IoT dissection. Maximum people have answered the correct answer. So can we have the leaderboard, please? Who has won? Let's see. So Dr. Dinesh Raja is the winner.
Dinesh, congratulations. So you will get the prize, the Amazon gift voucher and the free golden pass to Heart Failure Association of India next meeting. You will receive. So you send your details. Now, I hope you have entered your details correctly in the registration. Hope everybody enjoyed the quiz. What is the feedback from the participants who joined? Was it easy to?
You can put your feedback in the chat box. Those who want to put.
Okay. So this was a first attempt. So hope it went well.
We can
Thanks
ask
to
Dr. Dinesh to put his mobile number also in the chat box.
yeah, Dinesh, can you put your mobile number? Thanks to Vinay of Hallmark Events for doing this wonderful job of identifying this software and making this quiz. And thanks to Vijay and Arun and Sumita for having multiple sessions of trials today to make it perfect. So I think it went on well without much problem. So thank you everyone. Over to Arun for the vote of thanks and you are muted, Arun.
Yeah, thank you. I think it was a fabulous meeting, and I should thank the entire team who has worked behind this for such a wonderful session. We've had starting from Dr. G. Mohan, whose talk unfortunately got some interruption, but nevertheless it was a wonderful session on randomized controlled trials. And then the case presentation was very good. I thank the entire team from Government Medical College Kozhikode for bringing up this exciting case and all the presenters and and the examiners, Dr. Tarayan sir, Dr. Balachandar, who led the discussion very well, and many thanks to Dr. Jyoti Vijay, Vinay, Harish sir, and everyone who worked behind to have this soft key, and the feedback, the preliminary feedback that we've got is that it's been exciting. And as everyone has requested, yes, this is going to be a monthly affair. So, welcoming everyone to join for the monthly Heart Failure Masterclass, and we will have off-keys every time. You can inform your colleagues as well to join for every month for the Masterclass. So, thank you everyone. Thank you everyone who's worked behind. Thank you, Chopra sir, Venu sir, Ebra Woman sir, and the team HFAI, our sponsors, Sun Pharma, and Vinay and team, Sumita, everyone. So it's been a fabulous session and a rollicking start to the off-key series. Over to
Okay,
Harrison,
thank you.
sir.
Next, we had a very good attendance, even though we had two programs, the NIC, CSI, and the other interventional program running parallelly also. So next program will be on May 9th. So
May 9th, we may CSI is there. I don't know.
okay, so we will announce the dates subsequently. So it will be in May. We will have to. We have completed this the sessions of Calicut Medical College and the CTA MST. We will have a new set of institutes next time. So we'll inform you the details. So thank you everyone for joining, and good night.
Thank you, sir.
Thank you.
Good night, everyone. And so it's not just about two teams, about everyone who's going to participate. Good night.